Good morning, everybody. So today we are going to see about the imaging techniques which are commonly used in gastrointestinal tract, okay, and the anatomical perspectives. Okay, so we'll be studying various techniques, okay, with the abdomen, okay, and there are many imaging techniques which can be used in the GIT. Okay, so unlike the musculoskeletal, so where predominantly we use X-rays or the neurology, if you take the brain, we will be using CT scans and MRIs. Okay, the GIT, we will be using a combination of all. Okay, because most of the gastrointestinal structure, they are translucent, so they cannot be seen directly by the X-ray. Okay, so there are various techniques, okay, to find out the GI pathology. And in X-rays, like these are some of the modalities which we commonly use. X-rays like ultrasound, CT scans, MRIs. Okay, so in X-rays, we can use the plain X-ray. Okay, so we know that most of the abdominal organs are translucent. Okay, so that is they are radiolucent, that is they cannot be seen on direct X-ray, but still we use a plain X-ray to detect certain abnormalities, like for example, if there is a perforation or if there are any stones. Okay, so like ureteric stone, gallbladder stone. So for those things, okay, so we use the plain X-ray. Okay, the next one we use contrast X-ray. Okay, contrast X-ray, as the name indicates, we use an additional material to visualize the organ. Okay, to visualize an organ. Okay, a radiolucent organ. Okay, so for example, for stomach, we use barium. Okay, a barium meal. Okay, so we ask the person to take in the barium salt, which is safe. Okay, for most of the humans. Okay, so for most of the people it is it's safe unless they have any previous allergy. Okay, and that's why we use this contrast to see if there are any abnormalities, okay, in a particular system. Okay, okay, the next one is ultrasound, sorry, double contrast. So what is this double contrast? So here they use the contrast material and also the air. Okay, so they also use air, okay, to see the structures more clearly. I will be showing you the examples later. Okay, then the ultrasound. Okay, so ultrasound is another modality. Okay, CT scans, they can also help in diagnosing the GI disorders, especially the structures which are located in the posterior abdominal wall, okay, like pancreatitis. So those things which can be hard to be seen under an X-ray. Okay, so we can use CT scans or MRIs, okay, magnetic resonance imaging. All right. So here you can see. Can you tell me what X-ray is this? Is it a plain X? Is it a which type of imaging is this? It is a X-ray. Okay, it's an X-ray. Is it a plain X-ray or a contrast X-ray? First, let's look at this one. Is it a plain X-ray or a contrast X-ray? It is a contrast X-ray. Okay, it is a contrast X-ray because here you can see the stomach. Okay, it's right lateral oblique view. Okay, it's right lateral oblique contrast X-ray show of barium male showing the stomach. Okay, showing the stomach. Okay, so the person is asked to swallow. Are you able to listen? Are you there? Okay. So this is a contrast X-ray. So where we can see the stomach, you can see the fundus body, the pylorus, okay, the pylorus and the duodenal cap. Okay. Now this is another one. This is also a contrast X-ray, but what is the difference between this one and this one? This is a double contrast X-ray. Okay, so this is a double contrast X-ray. Okay, excuse me. So where we can see the structures more clearly. All right. Now, esophagus. You already know the gross anatomical features of the esophagus. Okay, so you know that there are certain constrictions in the esophagus. So one is at the level of the cricopharynx. Okay, the second constriction is at the level of the aortic arch. Okay, then just below it will be the bronchus and then the left atrium. Okay, and the last constriction will be in the diaphragmatic when it passes through the diaphragm at the level of T10. All right. So in order to visualize the esophagus, we do an X-ray. Okay, so this is a contrast X-ray because you know that the esophagus is radiolucent. You cannot see that in a normal plain X-ray. So we will be doing a contrast X-ray, and this X-ray is taken when the person swallows. Okay, so the person is asked to keep the barium material in his mouth, and then he is asked to swallow. So as he swallows, the clicks are taken. Okay, the pictures, the X-rays are taken. Okay, so this is a barium swallow. Okay, so this is very important. It's a barium swallow because the picture is taken when the person swallows. Okay, after swallow, it is called barium meal. Okay, so the time of swallowing, it is called as barium swallow. All right, so what do we know? What do we see in this esophagus? So in this esophagus, we will be looking at the contour of the esophagus. Okay, and if there are any abnormalities in the esophagus. Okay, so this barium swallow is not only used only in GI disorders. Okay, it can also be used in various other disorders like cardiorespiratory. Okay, like for example, if there is enlargement of the aorta or a dissecting aorta, coarctation of aorta, okay, or there is a bronchus which is constricting, or a congenital heart disease which leads on to enlargement of the left atrium. Okay, can you just let me know like any condition in which the left atrium is enlarged? Any condition? Yes, mitral stenosis. Okay, in mitral stenosis, okay, in cardiovascular module, last year you must have read. Okay, so in mitral stenosis, what happens is the mitral valve is so close, it's tight, okay, and it's stenosed, and because of that, the pressure in the left atrium builds up, okay, and the left atrial enlargement is found out, okay, and it is very difficult to diagnose the left atrial enlargement in a normal chest X-ray, okay, because in a chest X-ray, because you know that the left atrium is located posteriorly. Okay, so one of the modalities which was used previously, okay, was the barium swallow. Okay, so in the barium swallow, they will be look at the normal constrictions. If there is a left atrial enlargement, it will be more. Okay, there will be more constriction in the esophagus. Okay, also if it is also used to diagnose the esophageal stricture. Okay, and if there are any esophageal cancers. All right. So these are some of the techniques, okay, which they use, okay, the constrictions for esophagus. Okay, so the next one, the barium meal. Okay, the barium meal series. Okay, it's usually called a series. Okay, because they take the X-rays at a series of intervals. Okay, so it will be taken at when the person has swallowed, it will be taken at 0 minutes, okay, 5 minutes, 15 minutes, 30 minutes, 1 hour, and 2 hour. Okay, so we will be taking a series of X-rays to look at the barium, okay, and at which part the barium is. Okay, so suppose if you want to study the small intestine, I will be taking out the X-rays at 30 and 50, 15 and 30 minutes. If I want to study about the large intestine, I'll be taking at 30, 1 hour and 2 hour. Okay, so it depends on which organ you think that there is going to be a pathology. Okay, you will be taking X-rays correspondingly. Okay, so this is called as barium male series. So here you can see this is a contrast, okay, double contrast X-ray, okay, showing the abdominal region in the RAO position. Okay, what is RAO? Right anterior oblique position. Okay, so the right anterior oblique. So if the person is turning towards the right side, okay, and the X-ray is passed in an oblique direction. So in this direction, why do we take this position? Because in this position, you will be able to see even the duodenal cap. Okay, the pylorus and the duodenal cap, they are more clearly seen in this view. Okay, and these are the structures which you need to know, okay, in this barium nail. Okay, so most of the structures you already know in the gross anatomy. Okay, so here you need to just interpret it with your knowledge in the gained from the gross anatomy. Okay, so here you can see these are the rugae, the greater curvature, the lesser curvature. This is the pyloric, the orifice. Okay, the canal. Okay, and this is the body. Okay, this is the antrum. Okay, then here you can see the duodenal bulb. Okay, the first part of the duodenum, the second part of the duodenum, the third and fourth part of the duodenum. Okay, and here you can see this is the diaphragm. Okay, one of the most important thing which you need to find out is air under the diaphragm. Okay, so usually there is no air under the diaphragm. Okay, if there is air under the diaphragm, okay, so it's pathology which you need to find out, like what is the reason for air under the diaphragm. So it can be due to peritonitis, perforation. Okay, so that is one of the common things which you should not miss. Okay, so the diaphragm. Okay, look if there is any radiolucent area between the stomach and the diaphragm. Okay, so which might indicate perforation. Any doubts until now? Any doubts?
No,
All
doctor.
right.
No, doctor.
All right. This is yet another double contrast X-ray. Okay, showing the same features. Okay, the gross anatomical features of the stomach. So in your exams, they may give you this X-ray and they may ask you, pointing out as an arrow, like what is this? Okay, so don't say that this is a stomach. Try to answer which part of the stomach it is. Okay, so read the questions carefully. Okay, so they might ask you what type of X-ray it is, which view is this, and what is this organ? What is this organ? Which part of the organ it is? Okay, so these are the different parts of the stomach. Okay, so here you can see the same structures. Okay, so from the barium swallow, so you can see in the distal part of the esophagus. Okay, then it passes through the physiological sphincter. Okay, the gastroesophageal sphincter, and this is the cardiac end of the stomach. Okay, so this is the peristaltic constriction. Okay, a peristaltic constriction which moves the food material into the stomach. Okay, so here you can see this part is being zoomed over. Okay, it's been zoomed over to find out like if there is any pathology in this distal end of the esophagus. Okay, yet another imaging technique. What is this DC? It's the duodenal cap, the pylorus, second and third part of the duodenum. I'm just showing you the normal ones. Okay, so try to see the normal ones as much as possible. Okay, then you go in for the abnormal ones. Okay, so now this is taken, okay, at 10 or 15 minutes interval. Okay, so what happens now? The barium has moved from the stomach. Okay, and then This is the duodenal cap, second and third part of the duodenum, and here you can see the jejunum. Okay, the feathery appearance. Okay, the feathery appearance. Okay, when it comes to jejunum, you cannot see the complete part of the structure. See here, if you see the duodenum and the stomach, okay, you can see it is completely, it makes the outline of the stomach. But whereas in jejunum, as well as in ileum, sorry, jejunum as well as ileum, okay, so you can see only feathery appearance. Why is it due to? Why you can see only the feathery appearance? It's because of the
Plica circularis.
yes, plicae secularis. Very good. Okay, plicae secularis. So because of the plicae secularis, you know that these are structures which which increase the intestinal surface area. Okay, on the top of which there are villi to which helps in absorption. So because of this plicae secularis, there is a feathery appearance. Okay, and here you can see, as you know that the plicae secularis, they become less when it comes towards the ileum. So that's why the feathery appearance decreases as it comes towards the ileum. Okay, so then here you can see at a 1 hour or 2 hour interval. So these things you already know, the cecum, okay, ascending colon. What is HF? Hepatic flexure, transverse colon, okay, splenic flexure, descending colon, sigmoid colon. Okay, why the colon is like this? Because of the hostrations. Okay, you can see the hostrations. Okay, and there are constrictions which are present in the large intestine also. Okay, so that's why this is it looks like this. Okay, so this is about the barium swallow and barium meal series. The next one is CT imaging. Okay, so usually CT imaging is being taken during in case if we suspect any cancers, okay, or if there are any metastasis, not for the gastrointestinal structures. Okay, it's mostly for um, accessory gastrointestinal structures and to look for if there are any metastasis. Okay, so this is a CT scan. Okay, and here you can see the liver. Okay, and the liver. Okay, and this is the stomach. Okay, the cross section. Imagine this is a cross section. Okay, and here this is the IVC, means inferior vena cava, the aorta, okay, the right crest of the diaphragm, okay, and here you can see the spleen, okay, the spleen, okay. What is this SC? Any idea? It's a sympathetic chain, okay, sympathetic chains. All right, so here you can see the liver. Okay, so this is slightly below. Okay, so this is probably at the xiphisternal level. Okay, so just below it, you will be able to see the different levels. So in this level, you are able to see the gallbladder. Okay, so the aorta, right crest, the kidney. Okay, the kidney, spleen. Okay, the stomach, everything. Okay, so all the other structures. Okay, so in your exams, we may be giving you a plain CT scan, and we may ask you to interpret which structure is this. Okay, so which structure is this one? So I suggest you to go through as many CT scans as possible. So then, if you type CT scan imaging in Google, you will be able to see a lot of pictures. Okay, so try to correlate with your anatomical knowledge. Okay. This is even at a slightly lower level. So now you know that the liver, only a small portion of the liver, the left lobe of the liver is seen. Okay, the stomach is finished. Okay, so this is here at the level of the transverse colon. So you are able to see the transverse colon. Okay, the pancreas, the kidneys, okay, the right and the left kidneys. Okay, the aorta and the IVCs. All right. Okay, so this is an MRI picture. Okay, an MRI picture. So this also shows the different techniques. So here you can see in MRI pictures, you will be able to see the fat also. Okay, so the cat, for example, if there are any perirenal abscess, okay, or if there is any abnormalities in the fat which is present in the peritoneum, in the greater omentum, or surrounding the abdominal structures. So that can be detected using this MRI. Okay, usually the perinephric abscess. Okay, so that can be found out using an MRI. Okay, so this is a longitudinal section. So here you can see the kidney, okay, the liver, the spleen, okay, okay, and this is the psoas major. That's the perirenal fat. So pararenal fat. What is perirenal and pararenal fat? You will be learning it in your next module, which is the genitourinary module. Okay, another contrast X-ray which we use is the arteriogram. So the arteriogram, so where we inject a dye into the arteries to find out if there are any abnormality in the arterial supply of the GI tract. Okay, so here you are able to see the arteries which supply the abdomen. So here you can see the abdominal aorta. Okay, so the abdominal aorta dividing into common iliac. Okay, the common iliac which then divides into external and internal iliac. Okay, so this is through specific arteriogram where they pass a needle into the aorta and they inject it directly into the superior mesenteric artery to find out the different branches of the superior mesenteric artery. Okay, so what are the different branches of the superior mesenteric artery? You should be able to correlate with your knowledge from the gross anatomy. So you know that. So these are inferior pancreatic or duodenal artery, jejunal arteries, ileal arteries, ileocolic artery. Okay, which goes and supplies the cecum, appendix. Okay, the right colic artery and the middle colic artery. So these are the branches from the superior mesenteric artery. Okay, so they might ask you as an arrow like pointing at it at like what is the what is this name of the artery. Okay, and why do we take this? Usually in case of any ischemia of the intestines, we usually take out when we suspect any ischemia, we take this arteriogram. Okay, so the arteriogram. Okay, especially in case of GI tract ischemia, we take this, and here you can see the arteriogram, a specific arteriogram where the inferior mesenteric artery is being focused here. Okay, so what are the branches from the inferior mesenteric artery? So here you can see an artery here. What is this? They have not named it, the arrow. So that is the left colic artery. Okay, the sigmoid arteries and this superior rectal artery. Okay, you can see the catheter. Okay, the catheter is going inside the aorta and then they are injecting the dye here. Okay, so some more parts of the CT scans. Okay, there is some more detailed anatomy of the CT scans. So here you can see the abdomen. Okay, so here this is the stomach, and this is the liver. Okay, so this is the left hepatic vein, middle. Okay, and the right hepatic vein. Okay, the aorta, and there is S. The inferior vena cava. You already know that the inferior vena cava is located, it passes through the liver, right? So here you can see the inferior vena cava, the right, middle, and the left hepatic veins draining into the inferior vena cava. Okay, at a slightly lower level, so here you can see, the portal vein, okay, the hilum of the liver. Okay, so which is where the main content, the portal vein is located. Okay, the stomach. Okay, and a small portion of the spleen. Okay, sorry about the spelling. Okay, SPLEEN. Okay, so the small portion of the spleen is being seen. Okay, and this is the inferior vena cava and the aorta. Okay, at a even slightly lower level. So here you are able to see the antrum, okay, the gallbladder. Okay, you're able to see the gallbladder, and from the antrum there is duodenum. Okay, there is duodenum. So this is, you know, that it's, this is the right side, this is the left side. Okay, right and left. Okay, so these are the other structures. Okay, at an even slightly lower level, 5 and 6, the kidneys. Okay, and here you can see the number 6. This one is a pancreas. Okay, pancreas, the portal vein. Okay, kidneys, and just above the kidneys will be the, I think they have not shown that here. Okay, will be the adrenal gland. Okay, so that's not shown. Okay, this is the duodenum. Okay, the common hepatic artery, the celiac artery. Okay, the branches from the celiac artery. Okay, the celiac artery. Okay, the splenic artery which goes towards the spleen, and the common hepatic artery. Okay, so these are the different parts of the CT scan. Okay, arteriogram. Okay, and these are some of the other X-rays, contrast X-rays, which are taken to find out if there are any abnormality in the biliary apparatus. Okay, in the biliary apparatus. Okay, so these are the different ones: MRCP, ERCP, PTC. What is MRCP? CP, magnetic resonance cholangio pancreatography. Okay, magnetic resonance cholangio pancreatography. Okay, pancreatography. Okay, so what is it? Magnetic resonance, same. So they use magnet like MRI. It's similar to MRI. Okay, cholangiopancreaticography. What is the meaning of that? They inject a dye. Okay, they inject a dye. They will pass an endoscope. Okay, through the esophagus, stomach, duodenum, and from the second part of the duodenum, they identify the duodenal papilla, and then they inject a dye. Okay, a contrast dye. Okay, and then they take the X-ray. Okay, the magnetic resonance cholangiopancreatic, and then they take the MRI. Okay, so that's why this is called as magnetic resonance cholangiopancreaticography. Okay, ERCP. Okay, what is ERCP? This is CT scan, the same, but it is done in a CT scan. Okay, endoscopic retrograde cholangiopancreaticography. Okay, endoscopic, that is because they pass the endoscope. Retrograde, okay, why it is called as retrograde? Because you are injecting the dye in the opposite direction of the bile flow. So that's why it's called as retrograde. Endoscopic retrograde cholangio pancreaticography. Okay, pancreaticography. Okay, MRCP, ERCP. What is this PTC? Okay, PTC stands for percutaneous transhepatic cholangiopancreaticography. Okay, percutaneous. So sometimes some patients they might feel uncomfortable passing the endoscopic tube. So what they do is they use a percutaneous technique. They inject the dye from the skin. They will pass a long needle through the right hypochondrial region. Okay, and then identify the largest biliary tree. Okay, the right hepatic duct. Okay, the right hepatic duct they will find out. Okay, and then they will start injecting the contrast. Okay, so that will show both all the hepatic ductules as well as the drainage of the bile. Okay, from the liver until the duodenum. Okay, so that is with regard to the percutaneous transhepatic cholangiopancreaticography. Okay, so MRCP, ERCP, and PTC. Any doubts until now?
No, doctor.
All right. The next one, the ultrasound. The ultrasound is a bit beyond your scope, but still, I will tell you some of the features, okay, of the GI tract. Okay, so usually it is found to, it is done to find out if there are any organ wall thickening, or if there are any stones, or if there are any malignancies. Okay, so that can be found out. Okay, and mainly it is used because it's a non-invasive. Okay, there is no, very little discomfort for the patient. Okay, so that's why this is most often taken up as the first modality of treatment, sorry, of investigation, first modality of investigation in most of the GI tract disorders. So here you can see the sound, okay, the sound waves, they go inside and then they get reflected back. Okay, then it has been recorded by the ultrasound machine and then they interpret it in a 2D scan. So here you can see this is the gallbladder. Okay, and you can see there are probably some stones which are present in the gallbladder. Okay, a similar scan, okay, which also shows the gallbladder, okay, with the gallstone. Okay, gallbladder with the gallstone. Okay, so usually to find out if there are any biliary stones, it's found. Okay, with the regard to the kidney stones, I am not concentrating here. Okay, so that will be taught to you in the genitourinary tract. Okay, now let's see some of the abnormal X-rays. Okay, so here you can see the esophagus. It's a barium swallow. Okay, so near the distal end of the esophagus. Okay, so there is a small constriction. Okay, there is a small constriction which is uniform and smooth. Okay, and uniform and smooth. So this is usually because of stricture. Okay, stricture means constriction. So why does this stricture occurs? It could be because of the reflux esophagitis. What is reflux esophagitis? The stomach contents are going back into the esophagus. You know that the stomach has got is rich in HCl, okay, acid. So what happens when the stomach contracts? Okay, the meat which is stored in the stomach, okay, so they can go up, and when it goes up constantly, okay, it can cause reflux esophagitis and even stenosis. Okay, benign structure. Now here, compared to this previous picture, okay, so here you can see the constriction is smooth, whereas in this picture, okay, there is abrupt narrowing, okay, and irregular mucosa. You can make out the irregular mucosa because there is no smoothness. Okay, there is no smoothness. So this is a malignant stricture. Okay, so usually they may use, okay, they may use it for benign to find out if there are any benign stricture or a malignant stricture. All right, so here this is also another barium swallow, but here you can see a very large irregular, okay, space filling defect, okay, in the barium swallow, so indicating that there is a growth in the esophagus in this region, and that could be because of the most common carcinoma which is present in the esophagus. It is the squamous cell carcinoma. Okay, it could be because of that. Okay, the next one is esophageal achalasia. Okay, it must have also been taught. Okay, esophageal achalasia. So what happens is achalasia, okay, which means absence of peristalsis. You know, peristalsis is a very important part of the body. So where the food is pushed, okay, from the mouth towards the anal. So in case of absence of peristalsis, okay, so this condition occurs. Okay, it is called as esophageal achalasia. Okay, or it is also called as achalasia cardia. Okay, achalasia cardia. Okay, so here the failure to relax of the lower esophageal sphincter. Okay, so because of this, the lower esophageal sphincter fails to open. Okay, and there is a smooth, okay, tapered beak-like appearance. Okay, a smooth tapered beak-like appearance. Okay, of the barium swallow. Okay, so this is called as esophageal achalasia or achalasia cardia. Okay, achalasia cardia. Why it is called cardia? It's nothing related to heart, right? But why is it called as achalasia? Achalasia cardia. All right. Hello. Absence of peristalsis and sorry, there is a smooth tapered beak-like appearance. Are you able to listen to me? Can one of you unmute and tell
Yes,
me?
doctor, we can hear you properly.
Okay, okay, okay. All right. So this is another barium male. Okay. So in this barium male, a double contrast X-ray of the stomach is being taken. So you can see the outline of the stomach. You can see the diversity, and here you can see on the lesser curvature there is the spot where the barium male is stuck. Okay, where the barium male is stuck. So this can be because of the gastric ulcer. Okay, the ulcer. So the barium, the salts, they go and get to stuck to the ulcer. Okay, so this indicates that this could be because of a gastric ulcer. Okay, and here you can see an irregular filling defect. Okay, which can be due to a gastric carcinoma. Okay, in the near, quite near the antrum of the stomach. Okay. Now, intestinal distinction. So normally you can see the intestines, they are dilated. Okay, so when it is abnormal, okay, a small intestine, when it is dilated more than 2 to 5 centimeters, or 2 to 5 centimeters, 3 centimeters, okay, when it is beyond 3 centimeters, okay, it means that there is some problem. Okay, colon, when it is dilated more than 3 centimeters, or a cecum when it is dilated more than 8 centimeters. Okay, you need to think of any intestinal obstruction. Okay, leading on to intestinal distension. Okay, so here this is a normal X-ray. Okay, normal X-ray of the KUB region of the abdomen. So where no contrast is used. Okay, so and here you can see the normal gas distribution. So normally in an empty stomach, if you take an X-ray, so it appears like this. Okay, so because of the gas in the stomach, the duodenum, okay, and also you can see a small part of the gas which is located more along the course of the large intestine. Okay, but in the small intestine, the gas is not that much clear. Okay, so in the large intestine, you can see some mottled gas appearance. Okay, radiolucent, some parts which are slightly radiolucent, indicating the gas presence of gas. All right, so in case of intestinal obstructions, how to look for? Okay, so here this is the picture of an intestinal obstruction. So here you can see one thing, as I said before, the small intestine dilated more than 3 centimeters. Okay, and the air fluid level. So here you can see different fluid levels. Okay, different fluid levels. If this air fluid, above this is air, okay, and this is the fluid. Okay, because of the obstruction, the intestinal contents are present here. Okay, so if this air fluid level exceeds 2.5 centimeters, so that also could indicate that this is an intestinal obstruction. Okay, air fluid levels at differing heights within the same lobe. Okay, you can see they are at different levels. Okay, so that can also indicate that this is a obstruction. Okay, you can see this valvular convergence, okay, along the entire part of the small intestines. Okay, so you can see that. Okay, and this is obstruction on the large intestine. So as I said before, look at the length. Okay, so if the intestinal segment, okay, is more than 5 centimeters, okay, you think of large intestinal obstruction. Okay, and here you can see multiple fluid levels. Okay, multiple fluid levels. Okay, so indicating that this is a large bowel obstruction. Okay, sorry, I think it's the same. Okay, the next, the sigmoid volvulus. What is the meaning of volvulus? So there could be a mesentery along which, if the mesentery keeps circulating along itself, okay. So you know that the sigmoid mesocolon is present above the sigmoid. Okay, so this mesocolon, when it rotates amongst itself, okay, so it can link on to a large shaped abnormality like this. Okay, so this is called as coffee bean appearance. Okay, it looks like a coffee bean. Okay, so here you won't be able to see the hostrations because of the dilated segment of the large intestine. Okay, dilated segment of the large intestine. Okay, so in this case, you can suspect that this is a sigmoid volvulus. Okay, paralytic ileus or adynamic ileus or functional ileus. So what happens is paralytic ileus, like usually seen in post-op patients. So what happens in post-op patients? Usually they give general anesthesia. So when the general, after the general anesthesia, it will take a little bit time for the GI tract to regain the peristalsis. Okay, so if they don't regain the peristalsis, it's called as adynamic ileus or functional ileus or paralytic ileus. So how to find it in an X-ray? So you will be able to find gaseous distensions. Okay, there is gaseous distension of the abdomen, but there are no air fluid levels. Okay, there are no intestinal levels, so indicating that this is not an intestinal obstruction. Okay, always any X-rays, it has to be correlated with your clinical examination. Okay, so with your history taking and clinical examination, you need to correlate it to come to a diagnosis. Just by looking at an X-ray, okay, it is very difficult to come to a conclusion. Okay, so here in this case, can you see what is the abnormality? Pneumoperitoneum. Pneumo means air, peritoneum means air in the peritoneum. Where is air in the peritoneum? Can you see here? Diaphragm. Okay, so this is the diaphragm, and here you can see a small amount of air which is present. Okay, on both sides. Okay, so usually this air should not be present. Okay, there should not be any air. Okay, under the diaphragm. Okay, so if there is air under the diaphragm, you need to think of perforation. Okay, any perforation of the any of the intestinal organs, or it could be because of any recent laparoscopic surgeries. Okay, laparoscopic surgery or surgery, so that also could be a reason. Okay, so usually a person with severe severe abdominal pain, and then you take an X-ray. Okay, and if you find air below the diaphragm, it indicates that this is a case of perforation. Gallstones. So you know that only 15 to 20% of the gallstones, so they are radio opaque. Okay, they contain calcium. Okay, there are different types of gallstones. Okay, in pathology you might be reading it. Okay, cholesterol stones. Okay, bile stones. Okay, so there are different type of stones. Cholelithiasis. It's called as cholelithiasis, right? And there are many. What are the risk factors for cholelithiasis? The five F's. The five F's. Okay, it is pathology. You can read it from there. Okay. So fetus, female, flatus. Okay, so there will be a large number of five risk factors for increased number of gallstones in certain people. Okay, so here this is a gallstone. Okay, so this is a CT picture. Okay, so here you can see the liver, gallbladder, and the stones. Okay, the stones which are more clearly visualized in a CT scan. Okay, so the next one is porcelain gallbladder. So what is this porcelain gallbladder? It's a condition so in which there is a calcification of the gallbladder. Okay, so what happens? Why there is a calcification of the gallbladder? Suppose if there is a chronic obstruction or a stricture, okay, or a stricture or a cancer along the biliary apparatus. Okay, so the gallbladder will be distended for a long time, and when it is distended for a long time, that will be a calcification along its entire wall lining. Okay, and this is called as porcelain gallbladder. Okay, and here you can see multiple radio opaque structures. Okay, so these indicate calcifications along the. This is along the epigastric and in the left hypochondrial regions. So the structure which could be present here is the pancreas. Okay, so this is could be because of pancreatitis. Okay, it could be because of pancreatitis. Okay, so pancreatic calcifications. So this is a cirrhosis liver. So you can see the irregular appearance of the liver, a cirrhotic liver. And this is the fatty liver. Okay, in an X-ray, so where you can see the enlarged liver. Okay, hepatomegaly. Okay, and sometimes the radiolucent structures which are present inside the liver, indicating the presence of cysts. Okay, which in the liver. Okay, either because of you know that there are amoebic cysts or hydatid cysts. Okay, so it could be because of any of these conditions. And here you can see multiple translucent along the entire liver. So this indicates that it is a metastasis. Okay, if you see this appearance, it indicates that this is a metastasis. Okay, and once you find a liver like this, you need to start looking for the primary. So the primary could be anywhere. Okay, it could be GI tract, breast, lungs, esophagus. Okay, so it could be anywhere. Okay, in the liver metastasis. Okay, so you need to find out like where is the primary, and then you need to treat it out. Okay, any doubts?